meeting to order. Today is Thursday, January 15th, 2026, and it is 9:03 a.m. Public Health and Pharmacy Formulary Advisory Committee meetings are conducted in accordance with the Oregon Public Meeting Law. Under the Public Meetings Law, governing body meetings are open to the public except as otherwise provided by law. The presiding officer has the authority to keep order and to impose any reasonable restrictions necessary for the efficient and orderly conduct of a meeting. Governing bodies are authorized by ORS 192.660 to meet in executive session in certain limited situations. All official actions by the committee must be taken by public vote, and the vote of each member must be recorded. I will now take roll call. For the record, when I call your name, please verbally acknowledge here. Committee member Lorinda Anderson.
Here.
Committee member Andrew Gibler.
Here.
Committee member Catherine Hammond.
Here.
Committee member Courtney Sellers is here. Committee member Robin Virgin.
I don't see her on the call yet.
All right. Committee member Sarah Wickenhagen. Oh, committee member Sarah Wickenhagen, can you acknowledge here? Oh, we still couldn't hear you.
Stand by.
Oh, no, now we can hear you.
Okay.
You're here. Okay. Staff member Brianne Efremoff.
Here.
Staff member Rachel Melvin.
Here.
Staff member Gary Runyon.
Here.
Excellent. So we will now review housekeeping, meeting etiquette, and public comment information. So committee members and staff, please remember to silence all of your devices. Please identify yourself as committee staff member and your last name each time you speak. That's a hard one. Please speak clearly and one at a time, as it is critical for the public record. Please note that this meeting is being recorded and retained for public record keeping purposes. Public comment, when applicable, occurs toward the end of the meeting. The committee will not deliberate any issues or requests during public comment, such as formal requests or currently proposed protocols. We are actually not going to be meeting in executive session, it sounds like, today. Is that still correct, Rachel?
Yes, that is correct.
Okay. All right. We will now review the meeting agenda. Does any of the committee members have any proposed revisions to the meeting agenda? If you do, please say yes. If not, say no. Committee member Anderson.
No.
Committee member Gibler.
No.
Committee member Hammond.
No.
Committee member Sellers does not have any proposed revisions, and looks like committee member Virgin is still not with us yet. Committee member Wickenhagen. All right, is there a motion? Sorry, excuse me. Is there a motion to move to approve the meeting agenda as proposed?
Committee member Gibler, so moved.
Is there a second?
Committee member Anderson, second.
All right, we'll do a roll call vote to approve the agenda as proposed. Committee member Anderson.
Approved.
Committee member Gibler.
Approve.
Committee member Hammond.
Approve.
Committee member Sellers approves. And committee member Wickenhagen.
Bruce.
All right, the motion passes. Is there any discussion on the proposed meeting summary from October 22nd, 2025? Did everybody have a chance to review that? Is there a motion to approve the October 22nd, 2025 PHPFAC meeting summary?
Committee member Gibler, so moved.
Is there a second?
Committee member Hammond, I second it.
All right, and we'll go through our roll call vote with a yes or a no, please. Committee member Anderson.
Yes.
Committee member Gibler.
Yes.
Committee member Hammond.
Yes.
Committee member Sellers also approves. Committee member Virgin, we will come back to you. Thank you for joining us. I see you on the call now. Committee member Wickenhagen.
Yes.
All right, this motion passes. Before we keep going, Committee Member Virgin, are you able to hear us okay?
Oh, Robin, you're just on mute.
Okay, so looks like probably not quite yet. Well, we will get started if that's all right, and we'll circle back to Committee Member Virgin and make sure that she's officially on the record of being here. So we're going to start with an update from Executive Director Runyon.
Executive Director Running. Good morning, everybody, and thanks for attending today for the meeting, the content, and all the discussions that are likely to occur therein. Just to let you know, a quick update, we wanted to let the committee know that we'll not convene on March 5th, 2026. We don't have any proposed content or necessary protocol amendments to justify convening the committee at this time. So we intend to reach out if we need to convene a special meeting in between now and the next regularly scheduled meeting. Rachel, do you know when that is? September. And that's the only update I have. Turn it back over to you.
I'm on mute, sorry about that. We will now review and discuss mailings A and A1 regarding medications for opioid use disorder, starting with Executive Director Runyon.
It's the mail.
Just a moment.
Executive Director Running. Just a moment to get those pulled up. You
So we
can,
have
open,
to
you
use
can open one.
Oh,
Get you the other. I'll take a small.
yeah.
And while we're pulling those up, I would like to mention that we have two SMEs on the call right now, and a third will be joining at around 11 a.m. Emily Skogrand, and I'm sure I'm mispronouncing that, and then Aaron Stringfield. And I'll allow them to introduce themselves and give a little background in addition to any other comments they would like to make. Emily, would you like to start?
I would love to. Good morning, everyone. My name is Emily Skogren. You got the name right, Gary. That's a hard one, so good for you. I am a pharmacist. I work at OHSU, and I am an internal med trained pharmacist. I still do shifts on the inpatient side, but my more important and more exciting work is I spend time with our addiction care team. We call it the Impact Team. And I work to optimize not only care for any patients with a substance use disorder that are admitted to our hospital, but I also collaborate with other institutions to do lots of different types of education to many different multidisciplinary groups, as well as help make order sets and policies and guide practice change for many patients, not through our state, and then also I do some work nationally as well. Thank you so much for having me and for considering this protocol. This is near and dear to my heart, so I'm pretty excited about today.
Thank you, Emily. I would like to say at this point also, Emily put in so much work between, I think it was probably late spring and now. She helped organize meetings with other executive directors in other states. She did a lot of work trying to pull any and all information that exists in the universe. It seems like she's just sent me so much stuff on in terms of resources and what other states are doing, including the VA. And I don't even know how she got some of it, but it was impressive. And I'll just say that I could not have done any of the stuff that I did that we're going to go over today if it wasn't for the effort that she also put in. So Emily, I really appreciate that. And I know the committee does as well. And next, I'll turn it over to Aaron. Would you like to introduce yourself and say a few words?
Oh, Aaron, we can't hear you. Sorry. Nope.
How about now? Are you able to hear me?
Yes.
Yes.
Okay. All right. And so, yeah, my name's Aaron Stringfield. I'm a board certified psychiatric pharmacist. I work primarily Samaritan Health Services in Corvallis, Oregon, and Lebanon. I also do a lot of ambulatory clinical pharmacy with our substance use disorder population, prescribing under collaborative practice with our various different family medicine providers throughout the Samaritan system. And then I also am a associate faculty, adjunct faculty at Oregon State University, where I teach various different mental health related pharmacotherapy topics for the students there. But yeah, passion of mine is substance use disorder, psychiatric medication management, and yeah, happy to contribute and help wherever I can for this project.
Thank you so much, Aaron. Aaron also attended some of the meetings that Emily and I put together. So I appreciate all the effort that you invested in this as well, and appreciate the feedback on the protocols. Next, I'll just go over why this is so important to me in hopes that it might resonate with you and maybe dredge up some things that are perhaps a little more subtle in your own personal and professional history. So we can look at things through those lenses today. From the personal standpoint, I come from, those of you who don't know me, you can probably catch on to the Southern accent. And I was born and raised the first 4 years of my life in a coal mining town in eastern Kentucky / Western Virginia. And it's a very depressed area. You still get back there every now and then. A lot of extended family live there. And then I grew up in Tennessee from 4 on. What does that have to do with what we're talking about today? It's a very depressed area, and as you all know, West Virginia and parts of Kentucky have been ravaged by the opioid epidemic. I've lost family members to overdoses. I've lost friends to overdoses, even in opioid-related overdoses. Even in East Tennessee, I had to help bury a couple of friends that I played soccer with in high school. Probably no less than 10 individuals I went to high school with passed away because of opioid-related overdoses. So it really had an impact on me personally. And there are studies out there to show that it's not uncommon. I think about 43% of individuals surveyed said that they knew someone that had passed away because of an opioid-related overdose. Dissecting that a little further, about 13% of those people said that it significantly impacted their life, and about 4% of those surveyed said it involved one of their spouses, right? So we're not so far removed from that as we think. So that's from the personal standpoint why this matters to me. From the professional standpoint, I won't go into too much detail, but I'll give you a little bit of background as to what happened and kind of change my perspective, because it might also do that for you. This is what I shared at the OSPA annual seminar. I think it was in the end of September also. Working at Walgreens, kind of at the tip of the iceberg that became the opioid pandemic or epidemic, that we didn't really know what was going on at that time. We were seeing a lot of scripts come in, just stamped, universal, alprazolam 2 milligram, 5 milligram oxycodone, 240, gabapentin 240. We just stamped signatures. Coming from Florida, we had no idea what was going on, probably circa 2009, 2010. And so in that area in Pigeon Forge where I worked, East Tennessee, we didn't really know what we were doing. We didn't know how to handle it. District leaders didn't know how to handle it. I don't think we did as a profession, as a medical community writ large. We didn't know how to handle it. So we're just kind of flying by the seat of our pants. And what happened to me, and this is kind of the pivotal moment that forever shifted my perspective on things, and is really powerful and was probably the defining moment that still affects me today. And I think about it every time I think of a talk like this or involved in a project like this. Working late night, someone comes through the drive-through, 2 parents up front, and then 3 kids in the back. So there's this kind of visual divider, right? So you can see parents in front, divider, kids in the back. 2 parents were both picking up Suboxone. My tech came over and she said, "Hey, what do they need?" I said, "Yeah, Mr. or Mrs. Smith are picking up the Suboxone," and hung up the phone. And the tech just looks at me and goes, "Those kids aren't going to have a chance." And I thought, they're not. And then it hit me. And I think it was because of that visual juxtaposition, kids in the back, parents up front. And I just had a thought that I'd never thought about before. And I thought, wow, those parents that my technician is kind of judging were those kids 20 years ago. And the people that we're judging now are the people that we wouldn't think about judging, 20 years earlier. Is those parents were those kids. And I think that moment for me forever changed my life, especially in terms of how I look at this disease process and the people that experience it. Because I realized, okay, there is that link there. And then if you want to dig a little further, of course, most of you are probably familiar with the Adverse Childhood Experiences study that kind of links those together. And it talks about 10 different criteria. And it's really a measure of childhood trauma. And it's divided into 3 categories: abuse, neglect, household dysfunction, between the 10 criteria. And so the average population, I think, is about 12% of people have 4 or more risk factors. In the subset of the patient population that experiences opioid use disorder, it's around 50%, so over a 4-fold increase. So again, we see that link that I saw almost tangibly in person that day, between adverse childhood experiences or trauma and then the development of opioid use disorder. So for me, it just changed my perspective and allowed me to see the humanity in it. And I carried that forward and then started to realize, oh my God, there are so many ways that the medical community and the pharmacy profession, in particular, like we're failing these patients. And unfortunately, even though that realization happened around 2010, fast forward 16 years later, I believe that we're still failing that patient population. I'm going to give you some statistics and then we'll roll on to the protocol. I just think this is important because some of this may shape the conversations that we have today and may help highlight just what a significant issue this is, number one. But subsequent to that, because it's such a significant issue, what a significant opportunity is represented here today by the work that we're doing. In terms of the treatment gap, a Blue Cross Blue Shield study, 2017, over a period of time, they noticed an almost 500% increase in their members that were diagnosed with opioid use disorder, yet there was only a 65% increase in the medications used to treat it. Pretty big disparity there. So what we get from that is there are a ton of people that are dealing with this that never seek treatment, or they might seek it and not follow through. We have some statistics on that as well. That's highlighted in the next statistic, ER to pharmacy. So we know only about 28% of individuals that go and seek treatment for opioid use disorder in the ER that are discharged with a script actually fill it. So expressing that conversely, 72% of people don't. And that's huge. And I think there are some things that we can do about that. Also, there's a treatment gap that is in part due to pharmacy failure. There's a 2025 study that did a survey on retail pharmacies, and they concluded that only about 39% of U.S. retail pharmacies actually regularly stock buprenorphine. And that those numbers are dismal. It should be a lot higher than that, if not closer to 100% were available. And then there's the diagnosis versus medication gap, which the Blue Cross Blue Shield study talked about. 55% of adults with opioid use disorder receive some form of treatment, often just counseling or detox. And only 25% of those individuals actually receive the FDA-approved medications. And the statistics are a little lower in the youth. Only about 1 in 3 adolescents with opioid use disorder receive any treatment at all. And then the medicated portion of that, or the individuals that receive medication that's FDA approved, is only about 10% or less. And where do these protocols come in? A statistic that really hit home with me is there is an 8-fold risk in all-cause mortality and opioid-related overdose death in the 2-week period that the patient first goes without their medication. So if they've been stabilized, they go to one of these, I guess 61% of pharmacies that don't stock it. Hey, we can't get it. We just don't want to deal with it. There's an 8-fold increased risk of death in that 2-week period. And in a lot of cases, it's preventable. And again, I think therein lies some of the opportunity in the protocols that we're talking about today. There is a huge economic burden associated with this. There's a huge return on investment. There is a New York study that came out that says for every dollar spent, there is a $4 to $7 reduction in drug-related crime. And let's see, I have another statistic in here too about that. Let me find that one. And then in terms of Oregon, what does it have to do with us here? As you know, a 2024 study showed that we're second worst in the nation in terms of per capita access to community pharmacies. We're also losing other healthcare providers, including mental health care providers, in rural and critical access areas, including but not limited to the coast. As you may have heard, there was I believe $117 million budget cut from federal funds that happened earlier in 2025. And that also impacted mental health care services in the state. And I say the timing couldn't be worse. I read an article fresh off the press last night, hot off the press. I think there were 2,000 letters sent out by the federal government on Tuesday night indicating that there was $2 billion cut from mental health services and substance use related services. And that's hot off the press. Maybe some of you haven't even seen that. We don't know to what extent that's going to affect programs in Oregon, but it will. So over 2,000 programs have had their funding cut. And I think there will be long-lasting ramifications of that we probably won't see for years. So the situation's dire, and I just wanted to go over some of the statistics that kind of highlight, the importance behind what we're doing today, why it matters for us here in Oregon, and then get you to start thinking about why it actually might matter to you, because again, there are fewer degrees of separation between us and this disease process and those that endure it than you would think. And when you just have such a tremendous opportunity and platform, you think about the extent to which we are impacting what all of the pharmacists do in the state, and then in some cases, other complementary providers or collaborating providers. So huge platform, and I hope you take that with you as we go through this information today. So thank you for listening to me ramble in that monologue. So we'll start with mailing A, and we're going to go through the medications for opioid use disorder, MOUD, initiation of therapy, kind of cover page, or just call it a summary document. And this is going to be the same for the continuation protocol. So once we go through this and we get through the initiation protocols themselves, we'll see this again. So we probably need to go through it and in as much depth unless questions come up in the interim between now and the continuation protocol. So this was one of the documents that was mailed out, I believe, Friday night or Saturday. I think we forgot to add that in the initial mailing. And you might recognize this. The format's the same as it is for, I believe, most of the other protocols. I would say all, but hopefully all, at least most. So it just goes over the authority and purpose, as you know, the PHPFAC statutes in 689, 645. The authority to do what we're doing today, is located in 2025 Senate Bill 236. And I'll just read that so it's fresh in our memories. It says that pharmacists may prescribe, dispense, and administer to a patient medication for the treatment of opioid use disorder in accordance with a statewide drug therapy management protocol developed in consultation with a physician with a background in addiction medicine. We have 2 of those that have weighed in on the protocols, I can graciously say, by the Public Health and Pharmacy Formulary Advisory Committee, convened under ORS 689-649 and adopted by State Board of Pharmacy rule pursuant to ORS 689-645. Of course, there are some additional elements that have to be followed in our pharmacist division, 115-0330. There's a link to that there. In terms of the required documents, we just have 2 with the potential for a third. It's the intake form and then the assessment and treatment care pathway. And the additional potential the potential addition to that will be, we'll cover it at the end of the treatment care pathway, and it's related to the initiation or induction protocol itself. That might give a little more insight information to the patient and might help them induce the treatment at home. And we go to the next one, training registration requirements. I think because of the MAT Act, this requirement of the 8 hours of education and training, it's a DA requirement essentially. So anyone that is renewing it, if they didn't do this before, or individuals that are getting are applying for the certificate the first time, have to complete the 8 hours of training. And then, of course, subsequent to that, after they complete the training, obviously to prescribe this, a pharmacist will need an active DA registration. Then we scroll a little further down, we have resources there. There is the potential for a prescription template, but we already give the prescription information or what the induction protocol is going to look like at the very end of the assessment treatment care pathway. So it's not essential. So we can talk about that when we get there. And then we have the therapy provider, initiation of therapy provider communication template. We'd also talk about that a little later in the treatment care pathway when we're there. A lot of providers are going to look this information up in the PDMP anyway. And in the induction protocol, I anticipate a lot of the patients that are to come in actually don't have a particular provider, previous provider. So might be a moot point there, but we can discuss that a little later. And then we have the 2 primary resources that we used. When I referred to ASAM throughout the meeting, of course, it's American Society of Addiction Medicine. Their treatment guidelines we kind of relied on heavily, not verbatim, but just trying to piece together what something viable would look like for us as pharmacists. And then we have the SAMHSA, or Substance Abuse and Mental Health Services Association, Tip 63, Medications for Opioid Use Disorder, the full document. A lot of good information in there. And I've included something, so the highlights will tell you what we've amended since we sent the documents out. You'll see in the patient intake form, we did take out the question related to pregnancy, because it wouldn't lead to refusal of therapy. If anything, it might lead to additional counseling points. Those should be covered by the pharmacist anyway, as the pharmacist, as part of the requirements for counseling, would have the ability to determine what counseling is appropriate, what topics are covered, etc. So it was raised, if we don't ask questions about pregnancy, that pharmacists might miss the opportunity, if not the obligation, to talk about NOWS, or neonatal opioid withdrawal syndrome. And so here's a document from American Society of Health System Pharmacists, or ASHP, and that gives a background on that in case some of the trainings involved in that 8-hour requirement don't go over it in enough depth. And I would say it's fair to say that a lot of pharmacists may have, forgotten this between, they graduated 15, 20 years ago. Might not be fresh on the mind, but this is a good supplement, not required by any means. And we also thought that keeping it there, the resources at the bottom, when the pharmacist reads through this, would also be kind of an impetus, if you will, or serve as a reminder that, hey, yeah, maybe I do need to ask about that. And what's this, now? I'll look into this, and it would be a tool for them in the event that they're counseling anyone that's pregnant and receiving MOED therapy.
Yes, so I'm going to close it. So
Okay.
turn it back to Courtney.
Yeah, Courtney, I'll turn it back over to you. That's all I have for document 1.
All right.
Looks like Committee Member Gibler has his hand up.
Sorry, Committee Member Gibler, go ahead.
Well, thank you, Committee Member Gibler. Just a couple clerical comments or questions at the very first statement per ORS. Are you wanting to add another ORS link there with the and?
Right, we're missing. So in our other ones, we usually cite 2. We may have
Okay.
left that out, Andrew, so it should look like that. I'll take that out.
Okay, you can take it.
Yeah.
And then super minor, just if you want to add a period at the end of that paragraph there in the sub bullet after 689, 645. And at the very bottom, ASHP is American Society of Health System Pharmacists, not the American Pharmacist Society. And that's it.
Thank you. I'm going to have to edit this anyway.
Thank you,
Thank
Committee
you.
Member Gibler. Committee Member Wickenhagen.
Sorry, I have a couple comments, but they're later on in the document. I apologize.
All right, so we are approving just this one page. That's correct, right, Rachel?
So we're going to hold motions, I think, until the end. I think what Gary would like to do is to present each page of the protocol and ask you questions as we go throughout. And if we need to amend in real time. So before I close this document, we just wanted to make sure that there weren't any questions, and then I'll open the next one. Does that help? Okay.
That does help. Sorry, it's just the agenda looks a little different on my end. So
Yeah, it definitely does.
Okay. All right. Does anybody have any more discussion on this initiation of therapy section? All right.
Okay.
Executive Director Runyon, if you would like to continue on with the next document.
Thank you, Executive Director Runyon. So we'll start to get into the fun stuff now, and I appreciate any and all feedback, even if it's admin related or it's about a typo. There's no such thing as minor feedback. We'll take it all, the good, bad, the ugly, anything in between. We want this to be as seamless and well put together and easy to use as possible. So any feedback you have, we'd love to hear it. And so you'll recognize the top of this document is just a copy and paste. Once we get it pulled up, copy and paste from all of the other recent protocols. So didn't change anything there. And then we'll go section by section through the patient intake form. Again, keeping in mind, this is for induction of therapy. So either a brand new patient, and by brand new, I mean someone that has not been treated for opioid use disorder before, or perhaps they have, and there's been a clinically significant gap, which we'll talk about the criteria for that in the continuation or modification protocol. So they may have had a clinically significant gap, and we need to restart them with the induction. So the section 1 here was kind of lifted from the DSM-5 diagnostic criteria. We looked at including that as is or as was, but I felt it was kind of more advantageous and perhaps applicable and advisable to include it this way, taking some of the top points or the things that are most statistically likely for these patients to experience and listing them as symptoms, is what they are anyway. Listing them as symptoms in order to help the patient determine, if they have an opioid use disorder. Remember, because we can't obviously diagnose them, and then using some of the more clinical-based tools like the COWS or clinical opioid withdrawal scale. I think it's a scale. There are some elements in there that we're not entirely sure are appropriate for pharmacists and might be difficult to actually execute and hold up. So we landed on this, and you see the yellow highlights there. I'll say a couple of things about that. So per one of the physician SMEs, we added the last bullet point there, and it talks about kind of dysfunctional behavior in that the patient will continue to use opioids despite having a persistent or recurrent social or interpersonal problem caused or exacerbated by the effects of opioids. Of course, depending on where you look or who you ask, that is one of the core elements of opioid use disorder in general. Do you continue to use despite negative consequences, essentially? So we added that one. And then what I'll say in general, you may have noticed in document or in pathway to continuation and modification, we included notes at the bottom, and that was initially meant to give my AAG a little insight as to why I was asking the questions. And I tried to make those trauma informed. I tried to make sure that the reading comprehension level was appropriate. And then I got some really good feedback from a few different individuals that said, hey, we really like these questions. If I were a patient on the other side of this, it would just make me feel more comfortable. And so I decided to add some of those for your consideration today. I'm not attached to any particular wording or concept. I just think as a patient, I would feel that way too. I think these are disarming. There is a human element to it. And if I were on the other side of this, it would make me feel better about being honest. And we all know these forms are only as good as the information is in them. And that information is only as good as it is honest and accurate. So just kind of lowering that barrier, making the patient feel less stigmatized by these notes, this, kind of inviting language, I think is really important, but I'd be interested to hear committee member feedback on that. So the note here says, we include these symptoms because there are common signs that opioids may be taking up too much space in someone's life, and it's often hard to realize it's happening. Checking yes just helps us confirm that this specific treatment is the right match for what you're experiencing. So I'll open it up for committee member feedback on those new additions there.
Committee member Gibler.
I appreciate the effort to make this document readable at an appropriate reading level, that patients can understand what you're asking and not feel stigmatized. To that point, I would like to make a comment on the 1, 2, 3, 4th bullet point that says failure to fulfill major responsibilities. I would change that. Instead of failure, I'd say difficulty with major...
Maybe difficulty fulfilling?
Something to that effect, and give an example like holding a job consistently, staying in school. Because I don't know if people would really understand what's being asked in terms of what is a major responsibility, and they're certainly not a failure for not being able to do it. And then the other bullet point that's in yellow is the terms recurrent social and interpersonal problems, and the word exacerbated is not really appropriate reading level. Those are words that many people may not understand what that means. And so maybe rewording that in a little bit plainer language would be helpful. Unless you've already ran this through a program and that was determined to be appropriate, like 6th grade reading level or whatever our efforts are to align, but I don't think it would be.
Executive Director, and thanks for that feedback. We'll certainly do that. Might even be able to do that in the interim as we're going through the other ones, so we can get feedback on that if you'd like. I think those were directly or verbatim lifted from the DSM-5, which is why they were worded that way. But nothing says that we can't reword those, and I appreciate the ideas. So we'll work on that as we're going through.
Yeah, this is committee member Sellers. Thank you, committee member Gibbler. I think that's a really important point. I would like to add that I love the note at the bottom. I think that this is, like you mentioned, very disarming, and I appreciate the effort. And I'll turn it back to you.
Executive Director Runyon. So we'll move on to question number 2. Just talks about.
Committee member
sorry,
Wickenhagen. Sorry.
Sorry, committee member working again. Would it be possible to have that at the beginning? Just to start off the conversation that, I don't know, just a thought. The note.
Executive Director Runyon. Yeah, it would be possible if that's what the committee wishes. Is there any additional feedback from others, or what does everyone else think?
This is committee member Anderson. I like that idea. I think it could apply to the entire questionnaire, in fact. So maybe before you even get into the questions, right under the opioid use history area, you put that note to say that we include symptoms and questions because they are common.
This is committee member Gibbler. I agree with Lorinda, or committee member Anderson.
Okay, so something like that.
Yeah.
Yep.
Good consensus. Good to go.
Committee member Wickenhagen, thank you.
And I'll shore up the tables once we are done. Okay. Yeah.
Okay, Executive Director Runyon, thanks again for that feedback. We'll go into question 2. The only modification made here is, again, the note at the bottom. And this question 2 in and of itself doesn't necessarily represent a bifurcation of potential treatment. However, it's important perhaps for the pharmacist to know this, so they might have a little bit more information about who would be eligible for therapy, or have a little more information about the patient's history, which might help them counseling points, and in particular, might want to know, hey, if they took an extended release product that wasn't prescribed to them, what's the likelihood that a precipitated withdrawal would occur if induction of therapy occurs too soon? But again, we should have that fail-safe in the subjective opioid withdrawal scale at the end that determines whether or not a patient's in significant enough withdrawal, essentially, to initiate therapy. Any questions from the committee on this?
Committee member Virgin.
This is committee member Virgin. I like this statement, and I do believe that it's important to make it, because oftentimes when individuals have a bad experience with buprenorphine, they may not be amenable to coming back and doing it later. So I believe that this note is important and should stay.
This is committee member Anderson. I totally agree with that.
Executive Director, and we'll move on to question 3. No changes to this one since we sent the document out over the weekend. We'll move on to question number 4. I think there was, I added a word there. I think it was missing. And then I added the note again on this one. And we're asking about the opioid overdose. Again, given that context as to why patients might read that and think, I'm going to be judged, I did something bad, I don't want to answer this honestly. You're just saying, we ask this because knowing your history will help us provide the right education and tools to make sure you're protected moving forward. And then given that example, which is included in one of the bifurcations and one of the checklists at the end, like naloxone nasal spray to help reverse an opioid overdose. And I'll turn it back to the committee for any questions regarding those amendments.
This is Committee Member Sellers. For question 3, is the answer to that going to change what the pharmacist does or is allowed to do by this protocol? And I guess I'm just wondering if, I mean, I could see how it could be really start a great conversation and be a good icebreaker, but I'm just wondering if it's necessary.
Executive Director Runyon, appreciate the comment there. I would actually ask for a little input from either or both of the SMEs on that to see what they think. In terms of the treatment care pathway, and before I turn it over, what I'll tell you is not directly related to any treatment bifurcation, or it's not essential. And to answer your question, no, regardless of what the answer there, there is nothing disqualifying that would prohibit them from receiving a prescription if all of the other required elements are met. Yeah, I'll turn it over to the SMEs on that to see what we think.
Hi, this is Emily. I also don't have strong feelings that it would really change the therapy. I think it's a good question to develop a therapeutic relationship with a patient, but I'm not sure that it would change. I wouldn't feel strongly about that answer changing how or if I would offer buprenorphine to the patient. So I agree that it might be totally fine to remove it if that feels right to the committee.
Committee Member Virgin.
Committee Member Virgin, I also don't have a strong feeling about this particular question. One of the benefits I could see of keeping it in and then making a note to explain, there may be some benefit in addition to creating that therapeutic relationship in then helping a patient or making some recommendations for referral should they need to continue treatment or need additional resources. For instance, pain management versus other addiction services, mental health, etc.
Committee Member Sellers, that makes sense. I wanted to ask the question in case we could perhaps shorten the form, or if you think that this could, rather than bringing that therapeutic relationship closer together, present kind of another barrier, I guess was my concern. But I'd love to hear from Committee Member Gibler, who has his hand up.
Hey, Committee Member Gibler. Although it's an interesting question and there could be something that comes from it, I'm always a true believer when it comes to protocols that every question we ask a patient is linked to a decision that we make further down the protocol. And if so, we don't create questions that are interesting, but questions that are practical and needed to make a decision. So even for referral, we need to know if this answer to this question could dictate if we refer or not, then we need to have that built in the protocol somewhere down the line.
This is Committee Member Sellers. SMEs, I'd love to hear, after hearing some of that discourse, what you all think about question 3 and sort of where you foresee this going. And, and keeping in mind sort of the venue that this is going to be asked in and utilized in, and some of the inherent kind of time and resource constraints that may come along with that.
Yeah, I can speak about that. I think that, for information gathering purposes, understanding exactly why these patients are taking, different opioids, extremely helpful as far as designing like your induction or initiation buprenorphine strategy. Chronic pain is, going to be treated differently than if someone's just essentially primarily using illicit fentanyl, and can give you some valuable information as far as how you start the buprenorphine protocol.
So is that clear in the protocol that we're going to review, Aaron? What you just said?
As far as considerations for chronic pain versus
right, and
a mixture of
fentanyl
chronic
versus
pain,
oxy or something. Because I think it's more symptom related, right? When I was looking at the protocol.
Yeah, and so I mean, yeah, and it should be possible. Maybe it's possibly, I don't know. Emily, are you able to comment on that as far as considerations for chronic pain as a primary reason for someone using an opioid versus a mixture versus just illicitly using opioids, how that changes your plan?
Yeah, my understanding is that this law is written in a way that we are only able to prescribe it for patients with an opiate use disorder. And, chronic pain, you could have complex opiate dependence and maybe not necessarily an opiate use disorder. And so teasing out some of that certainly is a little bit more nuanced in many ways. And I also think that we need to step back and realize that this is statewide and resources in each county is going to be different. And so certainly that's a part of conundrum is how do we give a great repository of treatment options? And, if they're using it for chronic pain in your community, then you have this person to resource them to. I think that's a challenge not just with us, but everywhere, and knowing when and how to refer people out. I don't think that this question changes anything farther down in our protocol. And then there's a whole other question that says, do you want resources for any of these other things as well? Or it specifically has them request if they would like resources for it or not. So I don't think that this has any direct influence on the pathway that we would choose for our patients.
Yeah. Committee member Wickenhagen.
Yeah, further down in the protocol, there is a section that says treatment of chronic pain, do not prescribe. So it sort of does.
And I guess I would just have to say that that's immediately going to cause, I mean, buprenorphine is just a gray area in itself. And so, I mean, a lot of these patients have co-occurring chronic pain. And so you're going to have people questioning like, okay, well, they technically meet criteria for an opioid use disorder, but they also maybe they started using, the opioid just for chronic pain. And now it's morphed into what that meets criteria as an opioid use disorder. And so I think maybe just some considerations for the gray area that does turn into for a lot of patients and a lot of providers.
And this is committee member Sellers. Can I propose that we move on so that as we move through the protocol, we can come back to question 3 perhaps toward the end? Because I'm still leaning toward maybe getting rid of it because I feel like it's covered under a lot of other sections. But I think that as we go through section by section, that'll become more clear. Is that okay with the group? Okay.
Executive Director Running, sorry for that brief commercial break. With our regularly scheduled program, we do have the worst internet here in the agency building. It's kind of embarrassing, but alas, here we go. Thanks for being patient with us. We'll move on to section 2, medical history. You'll notice that I did change hepatic to liver function. Again, related to the accessibility piece. And I did combine, again, this is for the committee's review and approval. I noticed that in the continuation protocol in the treatment care pathway, for simplicity's sake, we group all of those together. So I did that in question 5, combining that with 6, just to say, have you ever been told you have liver failure, cirrhosis, or have you experienced yellowing of the skin, the eyes or skin? And then added the note there, we ask about your liver because this medication is processed there. You want to make sure your body can handle the medicine safely without causing you any extra stress. And I'll turn that over to the committee for discussion.
This is committee member Sellers. Does anybody have any questions or concerns about question 5 in section 2? All right. Well, I think we can keep going. Executive Director Runyon.
Okay, move on to the mental health portion of the medical history. This is one of those sections where I think the notes are of the utmost importance. It says, we know life can be overwhelming and it's common to feel alone or hopeless when you're dealing with these challenges. These questions are tough, but we ask because we care. If you're struggling with these feelings, we want to make sure you have the right support to keep you safe before we begin this part of your journey together. So this is the touchy subject about suicidality, self-harm, etc. And this is all grouped into one of the bifurcations in the treatment care pathway, just to make sure that the individual is not in any acute stress that might be further exacerbated by what can be, a stressful induction process, and to make sure we get them immediate care if they need it. So this note applies to the next few questions. I'll just go ahead and go to question number 10, read the note there, and then because these are all under the mental health portion of the medical history, just open it up to comment for questions 7 through 10 in its entirety, or their entirety. And this is a question about acute pain, illness, or distress. And I believe you were talking about this as we got back into the meeting. So the note here says our priority is your safety and well-being. If you're experiencing a health emergency, we need to get you stabilized before we can safely begin this treatment. And we're here to help you navigate those next steps. So I'll turn it back over to the committee for questions 7 through 10.
All right, committee member Sellers, I'm wondering what the committee thinks about maybe moving the note under question 7 up as a preface under where it says mental health. That's more consistent with what we did previously, to make it a little bit less, or make it more disarming. Oh, committee member Wickenhagen.
Yeah, just a concern. I mean, again, I would want to ask these questions of any patient if I saw them in clinic. But if you ask that question and they say yes, then is a pharmacist going to be able to manage those next steps?
Right.
And I leave that to you all experts.
It's Executive Director Runyon. We do have that listed as the bifurcation in the treatment care pathway, giving options for referral, explicit options for referral there, whereas in the other bifurcations, we just simply say refer to another provider, and there are reasons for that. We could hold off on that question and then evaluate it in the context of what we have listed in the treatment care pathway related to these questions. It's up to the committee how you want to handle that.
Committee member Sellers, would it be beneficial to scroll down or go to that document where we can kind of see how those questions impact the protocol? Would that help anybody?
Do a split screen.
Just so we can kind of gauge, like, is this going to be something that the protocol assists our pharmacists in managing?
Where
yeah, it's just scroll down. Look for the green on the left.
I mean, this is committee member Gibler. I'm fine with bookmarking this like we did with question 3, and just when we cover that, then we'll know that these questions have been asked and how it relates to the protocol. But that's just a thought.
Yeah, I like that suggestion, committee member Gibler. Thank you. Any other comments on the mental health section right now? And we'll definitely revisit it as we go through the protocol later on. Okay, Executive Director Runyon, back to you. They really do have the worst internet.
Yeah, they must. It looks like it's still recording though. So I guess there's that.
Yeah, I'm glad about that.
Yeah, I was afraid they were cut out when we were having that conversation up previously and missed some of it, but hopefully it was recorded. We're forget what we were talking about. So much for bookmarking.
Question number 3.
Yeah.
Yeah. Yes.
I would also, this might be, since there's some blank space to take up, one of the addiction med providers that I work with, Honora Englander, is going to be popping on around 11. So if you guys have any specific questions you want to bookmark for her when she comes on, we can just make note of that also.
It looks like they're coming back.
Hey, everyone. Can we just, we again are so sorry. Hotspots, like just nothing is working in this building right now. So unfortunately, we may need to go back because we missed if you had discussion on that portion of it. So give me just a moment and I'll share the document again. We're so sorry. Just a second.
This is Committee Member Gibler. On our end, it looks like it's still recording.
Yes, the record is still there. It just
okay.
means if you had changes you would like us to edit in real time, we wouldn't have heard anything.
I see.
Yeah. I think we decided to put a pin in it and move on to the next section.
Okay, so are we going back to number 3 or part 2?
Executive Director, and we do have the ability to pull up the corresponding question to treatment care pathway. Actually, staff member Melvin has that pulled up. If you'd like to evaluate that kind of in tandem, or you can move on either way.
This is Committee Member Sellers. I think, why don't we move on? I kind of feel like if we move on and like it's good to see things twice. It gives you a little more time to think about it and get the whole questionnaire kind of under our belts. And then I think it'll provide a little bit more insight.
All right, so I'm going to go back to
document 2.
Yeah, this one. Okay, so no changes here in 7 then? That's what I'm hearing.
Yeah, we can move past the mental health section, I guess the question.
Mm-hmm.
To review number 10.
I read that.
Okay, super.
Okay, Executive Director, and we move on to what I believe we've already discussed, the chronic conditions and pain. I know this is kind of a great area. I'd love to hear from the SMEs on this one as to the necessity of this and the utility of it also. I've seen it included in some of the questionnaires by various organizations. But again, as has been mentioned, does this create enough of an impetus for the pharmacist to head in one direction or the other when there's a bifurcation? So are you currently being treated for a chronic pain condition? Yes or no? Love to hear from the SMEs so what you think about this, and then we'll turn it over to the committee for further comment.
I mean, I think it is an important question to ask, certainly. If for nothing else, it should trigger, what are you using for chronic pain, or what your treatment therapies are currently being prescribed to you for chronic pain? Because that would certainly change if I would feel comfortable diagnosing them with an opiate use disorder and how I would start buprenorphine for these patients. So I do think it's an important question to leave in there. it could ask after a second question, what is the therapy?
Bless you, Executive Director Runyon. Thank you for that comment, Emily. Aaron, do you have anything to add on that?
Yep. Yeah. We talked about it briefly, but yeah, I agree with what Emily just said. She concisely, nicely summarized kind of my thoughts on it as well. I think it does have some value overall. I think the entire time we're thinking through all of these questions, all of them can be really important, but also logistics from the outpatient pharmacist standpoint. And like Andrew said, or committee member Gibbler said, what does it ultimately lead to as far as a decision-making outcome and time and logistics from the prescriber's perspective taken into consideration? A lot of great information to gather, but how logistical and practical would it be for these people who are going to be prescribing?
Well, this is committee member Sellers. I think this has to do also with question 3. I feel like question 3 and question 11 are trying to get at the same information. And I would propose that if based on the protocol, there's a hard stop where you're not giving folks Suboxone for chronic pain, which is what it looks like. If further down in the document, I guess just a simple yes, no would probably be sufficient, because there's not a lot of other decision trees that are going to go along with that. So I guess, I guess it kind of depends on, because it looks like we're saying just absolutely not if you have a chronic pain condition. Is that correct? Am I interpreting that correctly from the SMEs?
I disagree. Chronic pain is overlapping so frequently, and also it's often tough to gauge. It essentially puts some of the pharmacists in a position to kind of make a judgment call, I think, on what the actual diagnosis is.
Right. No, I understand. This is committee member Sellers. I wholeheartedly agree with you. I think it's just, there's a yes, no question here. And then if you go farther down on the decision tree, it says if the answer is yes, it says in big bold letters, do not prescribe, must coordinate with provider. So I don't think that the protocol itself lends to that type of decision making. Does that make sense?
Yep.
Yeah. Committee member Gibbler, your hand's up.
Yeah, since this committee member Gibbler, since this question is asking about being treated by a provider, what if the patient, going back to question 3, is using illicit opioids, using that illicitly to treat a chronic pain condition without a provider? And how would that dictate a referral to appropriate treatment of pain versus prescribing opioid use disorder? Because I think maybe we need to tease that out after all. If we need to refer someone who's got a pain condition and is using fentanyl or heroin to manage it, obviously they also have an opioid use disorder probably at that point, but maybe need to be under the care of a treating provider.
It's Executive Director Runyon. Committee member Anderson, I see your hand up. Before we go to you, what I'll give you in terms of context is that some of the guidelines I've seen in the event that a patient's being treated for chronic pain by another provider, they recommend collaborating with that provider before initiating induction. Because depending on the type of opioid they might be using, we could, of course, create a precipitated withdrawal. So let's say I'm going to a provider for chronic pain. They only prescribe me, 30 tabs a month. I'm chewing through those. I haven't found space to tell my provider about it. but I've worked up the courage to go to the pharmacy because I know this protocol and options out there. And said, hey, I'm being treated for chronic pain. I take oxycodone 5, one a day, but actually I take 4 a day, and I found some stuff, on the street to bridge that. I need some help. What would we do in that sort of situation? And there are certainly situations like that out there, probably far more common than you think. But what would we do in that case? And I think that's kind of the spirit of the question and where it's derived from in terms of other protocols that I've seen. If someone's being treated, and perhaps we could reword that, are you currently being prescribed treatments for chronic pain, to differentiate between them treating chronic pain independently with non-prescription therapies or illicit therapies versus prescription therapies from a provider. But again, that was going back to, it's recommended that you consult and collaborate with that provider. Committee Member Anderson, I'll turn it back over to you as you had your hand up earlier.
That was actually part of what I was going to suggest, is that we somehow add in like either a prescription, or are you seeing a provider, or something along those lines, to get at whether or not there is another healthcare professional prescribing for them. But the other thing I wanted to bring up was, I think something Emily had said, which was that I like the idea also of including something about, if so, what are you being treated for? That way, kind of what you brought up with precipitating withdrawal and some of the other things that we might be able to get at, like what kinds of medications. Because if they, because I do think that could change how we think about what we end up doing.
Committee Member Wickenhagen?
I think that's an opportunity maybe for asking for using medications that are not prescribed, because if you check the PMP, you would be able to have all that information.
That is a good point. And at the top, though, we also asked them to list the opioids that they are using regularly, correct? So we should have that information.
They're being honest.
I think we're gonna check the PDMP anyway, but to see if they're being honest. Yeah.
Yeah. And to be clear, I love asking them about, if they are seeing somebody for pain. I think that does sort of bring that clinical picture together. I just don't know. I guess I'm thinking about question 11 and question 3 as being somewhat interchangeable and maybe not needing both. And I think other folks are maybe focused on some other aspects of that. So. Can I propose we get rid of question 3? We were going to circle back anyway. I mean, is question 11, because that's part of the decision tree later on in the protocol?
This is Committee Member Gibler. I'm fine with that.
Sure.
This is Committee Member Anderson. I'm in agreement with that too.
30.
Yeah, need one more.
And Smeeze, do you guys have any opposition to that?
No, I actually agree with that exact pathway as well.
Okay.
Number 11
No
is a much
opposition.
clearer answer.
This is Staff Member Melvin. So for consensus for this group, we need one more committee member to agree to that. I think we heard 3. We need 4.
This is committee member version. I support that recommendation.
Thank you. So we're going to strike 3. We'll renumber later. And then 11 stays as is, adding language. Okay.
Executive Director Runyon. Okay, so we struck 3, and then we'll change the language on 11 to make that differentiation, perhaps to something like, are you currently being prescribed medications for the treatment of chronic pain? or we could add something about a provider, asking them about that. But if they are being prescribed that by a provider, again, as mentioned, we would probably see that on the PDMP. So up to the committee on how we want to approach that. Say currently being prescribed.
So we're going to get rid of treated here.
Being prescribed treatment. Being prescribed medication for the treatment of.
This committee member Gibbler, I think that's important, this wording, only because if there is a discrepancy, a large discrepancy between what a pharmacist sees in the PDMP and what the patient is telling them, that may shift the response and the dialogue a little bit. And I don't know if it will impact anything, but I think there has to be a level of honesty to appropriately treat a patient.
Executive Director, and thank you for that comment. And do I recall from earlier that we wanted to ask what the condition itself was, or what type of condition was being treated, or did we decide against that as a component of this question?
This committee member Anderson, I don't think I was suggesting the type of condition being treated, but rather what the medications that were being prescribed were. But you do make a good point about the PDMP, that if there is a prescription for opioids, then it should show up there.
This is committee member Sellers. Yeah, that, and then that initial section where they have an opportunity to write out what they're on.
Raise that issue.
Executive Director Onion, staff member Ed Vermoff brought up a really good point. I know a lot of the surrounding states, we have access to their PMP reports or an analog thereof. But what would we do in the event that they're getting something or their most recent prescription was not from the state? How might that alter the direction of the treatment care pathway or our considerations? And it may not.
Committee member Wickenhagen.
Yeah, as a prescriber, I would say, I mean, you only know what you can know, and you can ask. And I mean, we can't think about every scenario, right? So it sort of is what it is. If they're going to be honest, and then the access that we have.
Okay, Executive Director, and thank you for that feedback. Unless there are any other comments, we'll move to reproductive health and pregnancy status, which I took out or struck through for the reasons I've expounded upon in the introduction to the overview form, document 1. So we have, again, the primary concern was the neonatal opioid withdrawal or opiate withdrawal syndrome. We have the APHA reference there. So are there any comments from the committee about removing this?
Can I make a comment? If we remove this question, how would the pharmacist know to trigger to cancel on nows?
Oh, Executive Director Onion. So that this dialogue is exactly what I wanted. I'm not entirely sure about that. I would say, playing devil's advocate, the same way the pharmacist knows to counsel on any pregnancy-related condition when they're filling a medication in general. I don't know if that's an answer that the committee's comfortable with or not. And we can certainly keep that in there and then add a bifurcation that if yes, we can refer them to that document or tell them to counsel on it. It's just we didn't include counseling steps for any other conditions, like respiratory conditions, kidney disease, sleep apnea, etc. So wasn't sure what we wanted to do. If we wanted to isolate this particular one and cover that as a counseling point while ignoring some other relevant ones. But, thank you for the feedback. It's exactly what I wanted. And I'll open that up to the committee for further consideration.
This is committee member Sellers. I guess, yeah, I appreciate that. I think it is kind of a good reminder. I do agree that obviously practicing as a pharmacist, these are considerations that you're thinking about anytime that you're filling a medication or counseling on it. But I do think that, it's a relatively extensive protocol, so I want to try and give everybody the best shot at success. And I also like things to be in one document as much as possible. I don't know how other folks feel about that. So I would be okay leaving it if you guys think that that would be counseling points, but it's not necessarily gonna, it's not gonna change what we do. So committee member Gibbler, you came off mute.
Oh, thank you. Committee member Gibbler, I tend to agree with Director Runyon on the comment that this is a counseling point. That's an important counseling point, but that we normally do not list the counseling points unless it is part of the decision tree in prescribing. So I am fine leaving this off, but fully acknowledging it's important to know when you're counseling a patient.
Committee member Sellers, I'm fine with that too. I just kind of trying to play devil's advocate there for a little bit.
Executive Director Runyon, one thought that might assuage any concerns that either have been expressed or exist and have not, and I can't promise anything or the timeline. One thought that I had is at some point in between, let's assume that the committee approves this protocol, sends the board, they approve them, then we go to the next steps of submitting these. And there are complementary rules to the DEA in order to get them to update their list to approve pharmacists as mid-level providers for the purposes of registering for the DA number certificate for registration. That would give us some time, because as I gather, that can be a months-long process. Several months. Other states have had that take up to a year, especially with all of the federal cuts that continue to happen. So that would give us, and I guess us as in me, some time to draft an optional counseling document that goes over a lot of the major counseling points that we would like to ensure pharmacists are covering. And we all know, or at least I do, maybe counseling doesn't always happen the way it should. And understand there are a lot of reasons for that. But that would give us some time to come up with that, and perhaps at the next meeting before this gets approved. I don't know that this entire process is going to resolve by September when the next scheduled meeting is. It would give me time to put together a document that covers NOWs, things like sleep apnea, other comorbid conditions where, it would highlight a certain subset of counseling points that we really want to make sure from a patient safety standpoint that the pharmacist is covering. Because again, this is going to be a new process for a lot of them, even though they're used to counseling on buprenorphine, we hope. But again, 61% of the pharmacies aren't regularly carrying it. So it would give me time to put together that document, and I could bring it back.
This is committee member Gibbler. I think I'm confused. The timeline for these documents, you said that we will be reviewing them again, possibly in September, or are there certain documents we're actually going to approve and it goes to the board?
Executive Director Running. So if the committee feels it appropriate, you'll approve everything we're submitting today with amendments. I was specifically and solely referring to creating an optional, patient counseling document that covers all of these points that we could just bring back and potentially add to this at the September meeting.
Staff Member Roth, I think maybe the key piece, the question that's being asked is that this would go to the board in February for the board to review and adopt. And if the board adopts, then it'll be put in rule. And then the DEA will be willing, because we asked them already ahead of time, to then look at our state to see if they will assess the DEA registration, which is required to be able to use this protocol. So there will be a lag time for us waiting on the feds to be able to get that implemented, and that you could do that other downtime work potentially to show the committee if they wanted to add at a later date at any time, potentially could even 2 years later, depending on how things go.
Thank you for that clarification.
This is Staff Member Melvin too. Also, Committee Member Gibler, we are going to propose that this be a temporary rule at the February board meeting, so it can go into, it can be effective immediately if the board, that direction.
Thank you.
Committee Member Wickenhagen.
My only concern with the temp rule is at some point it's going to expire.
Yes, so what we will do, this is Staff Member Melvin again, is the board will look at this again in April at their board meeting that's already scheduled, and then there's a rulemaking hearing scheduled for May, Sarah, so they would, if they agree, they would send it to the May rulemaking hearing and permanently adopt it in June.
Super, thank you.
Yes.
Executive Director Runyon. Okay, we'll move forward. Thank you for all the feedback. His general symptoms section that has one question, we whittled down from 3 questions. It was really kind of geared towards that subset of patients that may be injecting drugs and could be experiencing some symptoms that might indicate endocarditis or another occult infection. So the decision tree itself or the rubric was pretty complicated, and the SMEs recommended cutting it down to the most essential element was, which is, do you have a fever, feel warm, chills, or unusually confused or dizzy today? And this would be a reason to defer to another provider. I'll open it up to any questions on this one.
Committee Member Wickenhagen.
Yeah, I worry for my colleagues about the liability here. Yeah, I guess enough said. Like urgent care referral, or because they're not going to get into a PCP the same day if they have those symptoms.
Can you clarify what this Committee Member Gibler, what the decision tree looks like on that? Is it a referral to anything in particular? I mean, it was just a few years ago, this could have been COVID and still could be the flu or something, but.
Executive Director Runyon, I think this is, one more down.
10.
No, you had just passed it. Yeah, right there.
You don't have to share screen. Let's just pull it up. Question 8.
Executive Director Runyon, so this is question 8, and it says simply, do not prescribe, refer to another provider.
And so this is Committee Member Gibler. So when we write this, I mean, in previous protocols, we were explicit in what kind of provider. Sometimes we would say call 911 or go. I don't know if we go to recommend urgent care versus PCP. This is very generic language. I assume the pharmacist would just use their own judgment on this and know when to refer to urgent care versus scheduling an appointment that may not be for several weeks.
Executive Director Runyon. So this is a point that came up. I think in the initial iteration of this, I had something like refer to call 911, refer to ER or urgent care, etc. And then internally, the question was brought up. Well, those are three options. How do I pick, one and then go to the next? Can I just pick urgent care to begin with? What if there's no urgent care appointment available? Is there a warm handoff that's required? So this is a great point for committee discussion. We can certainly include any particular thing that you want, just understanding that, that may create confusion and potential conflict in the protocol when we're giving all of those options and allowing for judgment within the confines of the protocol or as directed. And pharmacists may not necessarily either know what to do in that situation. We give them those options, and it may create additional liability if they can. I'm not really sure how to handle that. We did have that initially in the protocol and took it out, except for in the situation where it was potentially arguably and unavoidably urgent, like the suicidality question, where there was an immediate threat, and then we did spell out some potential options depending on the nature of it. I see some hands up there.
Yeah, Committee Member Hammond and then Gibbler.
I keep looking at the term unusually confused as something we may want to consider changing. A lot of people who are actually confused don't realize they're confused, for one thing. But also I keep thinking like maybe that's just like not the best way to. I think what you're trying to ask is, does this person feel really unwell today? But I don't know if unusually confused, because I mean, if we have somebody who's actually confused, they're probably not going to be able to answer half these questions. I don't know. Anyone else think that's kind of an odd way to document that?
Committee Member Sellers agrees. Yeah. Committee Member Gibbler.
You can just take out unusually. Mm-hmm. Just say confused.
And then
I think my comment is, if we're really trying to make a judgment call whether they have MRSA infection or endocarditis, they need to go to ER. So I don't want to refer to a provider. I want them to go to the ER if they answer yes to this question, to get a full assessment, because there's a lot of imaging that needs to be done to determine that can't be done in urgent care.
Executive Director Runyon, I do agree with that. And then, but also to your earlier point, what if it is just, some other bacterial viral infection? Would that necessitate, and obviously we can't provide a differential in that environment for pharmacists at all, would that necessarily
we're not in the business of diagnosing, so they need to go to ED. If it's a bacterial infection, it's most likely MRSA or some other drug-resistant organism in this population if they're IV drug users. So I would be very hesitant to make any referral other than ED, but I'm open to others weighing in, including the SMEs.
Committee Member Sellers. I agree. I mean, obviously, if they're really, really sick, like there's not, like the ED is going to be the only place that they can get immediate treatment, which is what would be necessary. My thought when I first read this question was that the way that it's phrased versus like the SOWS assessment, which is coming up later, there's a lot of crossover between these symptoms and the symptoms of withdrawal. So are we potentially like, is there a better way to phrase it where it's like you can sort of differentiate an infection versus withdrawal symptoms? Am I totally missing the point here? It's okay if I am, but I'd love to hear from the SMEs.
Yeah, and I can actually make a comment on this based on one of our addiction care providers, Bradley Bukite, who had looked over this protocol, and he had actually suggested that we think about changing it to acute illness other than acute opiate withdrawal, or just making it clear: are you sick other than an opiate withdrawal symptoms that you may have? Usually, patients know when they're in bad opiate withdrawal versus, in my experience, something else they're able to really differentiate between.
And Committee Member Virgin, I'll get to you in just one second, but can I also ask, so why did that suggestion not make it into the protocol?
It was a last minute suggestion.
Okay.
It was after I had sent Gary my initial go rounds.
Okay, thank you so much. Committee Member Virgin.
Yes, Committee Member Virgin. Also just wanted to state that we have some tense problems with this statement as well. Did the patient complain of, it should have been having a fever? Did patient complain of have a fever? Is incorrect. I would also, I just wanted to state that I also like the idea of, did the patient complain of feeling particularly unwell with fever, dizziness or confusion? Something to that extent.
Thank you. Committee Member Gibler.
To the point that was mentioned earlier, maybe we could also add language that the patient felt is due to withdrawal or is due to acute illness or something to that effect. Somewhere maybe that's teased out in the original patient intake form and then here, because that'll determine where we go.
Yeah, Committee Member Sellers, I actually would propose that on the questionnaire that we strike the question and substitute it with the statement that SME Emily had mentioned. Does that make sense? So instead of like being really specific on it, being like, are you sick in a way that's not for a reason other than opioid use or opioid withdrawal. I'm sorry, guys.
This Committee Member Gibler, just I like how it's worded, but Dizzy, today that you feel is due to a new illness or new sickness or new, trying to think of appropriate language. I mean, acute infection is not very friendly in terms of language. But something, just tag it on to the end that you feel.
Committee Member Anderson.
Thanks. First, I think Aaron has lost his ability to speak. The big question I had was kind of maybe going back to why we need this question in the first place. Like, is it going to cause harm to prescribe somebody Suboxone that may have endocarditis? I guess that's my big question. Like, what was the reasoning behind needing to find out if somebody has endocarditis? Beyond just maybe if they have a history of IV drug use.
Executive Director Runyon, I'll refer to the SMEs on that one and go back to, again, that this question was one of three, which asks about recent injection drug use, number one. Number two, if the individual had any like, open sores, lesions, etc. And then number three asked this question, and depending on how they answered either yes or no to that series of questions, there were different treatment options or recommendations. But from what I've seen in other protocols, if there was the suspicion of endocarditis, then treatment, but because that, again, the induction itself can be physically and emotionally stressful, that it was a hard stop and a hard referral to the ER in and of itself because of those two things. But I'll open it up to the SMEs on that one for further comment.
Sorry, go ahead, Aaron. I saw you unmute first. I should have used my hand.
No, go ahead, Emily.
I don't think that there's any like sepsis, endocarditis, any of that stuff is not a hard stop from prescribing buprenorphine, and we certainly do that in the hospital. But to Gary's point, that undergoing buprenorphine induction can be quite stressful, and then you add an acute illness on top of it. Additionally, that's just good patient care. If someone is sick where we think that they have sepsis or we think they have potentially have endocarditis, as a healthcare provider, I'd want to encourage them to go and get more or a higher level of care than I can offer them. Would one argue if you get them stabilized on buprenorphine, are they then more likely to present to care? Yes. But I do also think it's good practice when we know someone is septic or ill that we get them the resources or encourage them to get the proper level of care for their acute illness.
Executive Director Onion. One quick thing I would add to that as well. I'm looking at the long-term effects of that in starting buprenorphine under this induction protocol that we know can be physically and mentally taxing, and what the patient might then associate with the buprenorphine itself. We all know individuals that, or at least over my career, I've seen people that say, no, I can't take insulin because when I started, immediately after my vision went bad, or I had to cut off my foot, it's related to the insulin. But starting this induction therapy in someone that's undergoing or experiencing some acute illness, we don't know what, cause them to be less likely to continue it if they have a bad experience, and then attribute some or all of that, because that tends to be the habit, to the buprenorphine when it's completely unrelated. So if they have a bad experience, I could see the potential for that affecting their long-term maintenance therapy, but just a thought.
Committee member Virgin. Oh, sorry. Sorry, Lorinda, go ahead.
Sorry, just to kind of, I guess, come full circle on that, because I think what is happening is that we're all kind of, bringing up that this is a really generic kind of symptom that pops up with lots and lots of illnesses, and that, maybe it's something that and maybe, yeah, I agree that, going through an induction type therapy might, have problems if they're sick in general. So sure, maybe that's what we're trying to get at. And if that's the case, then maybe we just reword this to say, like, have you been getting, or have you been feeling sick? And then list a few of the other types of symptoms. I don't know. I guess I'm just trying to bring it back full circle.
I almost am. Are you guys able to hear me? I'm just checking. You are, okay.
Yes, we are.
I'm almost wondering back, maybe taking a little bit of like a step back, as far as the, I guess, breadth of these medical questionnaires, assessments, and whatnot, and how broad they are. I almost wonder if it might be helpful to outline the most important questions that are going to require check marks for the pharmacist to walk through the patient with, and then have a separate section that is a consider also section, assessing based off of your impression of that patient, and then list different options and considerations for the pharmacist to ask that patient based off of that interaction. It just seems like some of these are possibly going to maybe be just extending a lot of the pharmacists beyond what they'll have time to take on. I love the depth of all the history taking, and it's very helpful, but logistically, I just wonder about how many questions are being asked and how in depth they go, and how much burden that puts on the pharmacist to make some of these decisions.
Committee Member Virgin.
Yes, this is Committee Member Virgin. Now I have a couple of different thoughts since I put my hand up. So initially I was thinking about language for this statement. And then I guess I come back to, is it based on our discussion points, is it more consistent with the reason we struck 12 and that we wouldn't want to delay treatment if someone was open and interested? And that this is more of a point of education for the patient and or, guidance to, seek higher level of care. So I'll put that out there to the rest of the committee. If we did want to maintain it to keep the sentence structure short, I had thought that just confusion or dizziness or feeling confused or dizzy due to illness other than due to an illness and not withdrawal or illness other than withdrawal.
Executive Director Runyon, I like that. Do we think, because this as worded would imply that the patient knows whether it's one or the other? If we say something like that you think is due to an illness other than withdrawal, would that make sense? Because it would be a suspicion either way. They may not be able to differentiate.
This is Committee Member Sellers. I agree with that.
Committee Member Gillar, I like that language too.
And this is Committee Member Sellers. I just want to do a time check. We've been at this for an hour and 50 minutes. We do have our physician champion, I'm not really sure what the actual title is, joining us in about 10 minutes. Can I propose a 10-minute break and we can reconvene at 11? Okay. Any opposition? All right. Rachel, did I do that okay? Can we just break now?
Sounds
Okay,
good.
all right,
You all
perfect,
can
thanks.
just stay on the call and just mute,
Yeah.
and that would be great. And we'll see you at 11.
Thanks.
Thank you.